but while we're waiting for Oscar, let me preface this with a couple of disclosures. One is that I've known Ari Wajdani since the early 1980s. Whoever's typing, if you could mute yourself while you type, I'd appreciate it.
There he is.
Hi, Oscar.
Hey.
I was just mentioning that I've known Ari Wajdani since the early 80s when he was at UCLA. At times he's had his own lab. Right now he's consulting to a lab and advocating for that lab. But I would, if it's okay, you're welcome to ask some questions, Oscar, and I'll give you specific answers, but there's a context in which all of the questions reside. And that context requires you to be a laboratory scientist, you know, my double boards in clinical pathology qualified, but also something of a quality control expert, and at the same time, a clinician interested in function more than physical chemistry. So with that said, I'm happy to answer some questions. I'm happy to start with how the immune system, how a reasonable person's immune system has multiple defenses that would prevent the virus from getting in. And more importantly, if it got in, the innate immune system would, by phagocytosis, put it in a lysosome, break it down to its elemental building blocks, and let the body have the results. No recognition in regard to infection. However, on the mucosa, on the surface of the body, whether you're talking about skin or, you know, and by the way, the FDA says that mucosa starts at the stomach. They do. They're very clear. It's not true, but it's there. If you say dissolve something under the tongue before swallowing, that's fine on advice of counsel, but they very specifically prohibit the use of the word sublingual. So there's the innate immune system and there's the adaptive immune system. But before you get to the innate immune system, there's the mucosal defenses. And we do want to spend time talking about SIGA, secretory IgA, in saliva and or sputum. And when you get to the level of adaptive response, you know, the reserve troops that are called in when the innate immune system is exhausted, overwhelmed, lacking in antioxidants and magnesium, too acidic, and not able to engulf the 50 organisms per cell. So you've got 50 billion cells. When they have enough ascorbate and magnesium, they can engulf 50 Bacillus subtilis in a test called phagocytic index. It's an old-fashioned test, but good labs still run it. Nobody promotes it because it's not patented. But phagocytic index is the functional test for the innate immune system. When you get to the adaptive immune system, it gets even more interesting and complicated because IgM comes up first and goes down. IgG comes up later and stays. But if you just do a standard ELISA for physical chemistry, presence or absence of IgM or IgG antibodies, you do not know. You have no information about function. And you must, to get reliable data, distinguish neutralizing antibodies, which are good for you and protective and should stay indefinitely as long as you keep a reasonable immune defense and repair system. In contrast to the complement fixing harmful antibodies that people who have been treated for certain medical conditions have a disposition, a comorbidity disposition towards. And the comorbid contingencies, comorbid variables, do actually explain near 100% now of the catastrophes. So it's not a very aggressive virus. It is a coronavirus. It is a respiratory virus. Yes, the COVID-19 is more infectious and reveals certain deficiencies in people, like ascorbate, antioxidant, and magnesium. You can throw in zinc. And if you look at the functional physiology of what we do as integrative, comprehensive, personalized care specialists, you can explain the catastrophes, the blood clotting catastrophes, the cardiac, the respiratory, etc. And we may want to talk a little bit about vitamin C, what kind, how much, what route, and for whom. We certainly want to talk about magnesium enhanced uptake with choline citrate based on urine pH after rest. And anything else that is of interest to you.
Russ, can
So,
I ask about neutralizing antibodies? Are they
absolutely.
always IgG? Are they a subset of IgG or are they a different antibody altogether?
No, that's right. If you look at any textbook of immunology, they will explain that IgG antibodies come in two flavors: the neutralizing, beneficial, and protective, and in contrast, the complement fixing, harmful antibodies. Now, Burson and Yalow got the Nobel Prize in the 1950s for doing an amplified procedure called enzyme-linked immune sorbed assay. There are thousands of those, but all of them are physical chemistry from the 1950s. And none of them tell you function. None of them distinguish a neutralizing good antibody from a complement fixing bad antibody.
So even in our antibody tests that we're using now, we can't distinguish one from the other as they stand.
The COVID-19 antibody tests, whether they be IgM or IgM and IgG, and at this point you should be probably measuring both at the same time. They do not distinguish helpful from harmful. They are standard enzyme amplified procedures, no functional information possible. Dr. Birx and Tony Fauci have both been quoted as saying that's a huge defect. And when you get to the adaptive immune system, the T cells that don't use antibodies turn out to be more important than the B cell based antibodies. So the sensitivity and specificity, the ability to use information from an IgG antibody test to make a prediction, predictive significance. There may be better tests coming. I hear there are better tests coming, but the ones that are approved by FDA today, all, according to the American Association for Clinical Chemistry, of which I'm a fellow, and the American Society for Clinical Pathology, of which I'm a fellow, say the test is not sensitive or specific enough for clinical use. For population profiles, okay, and we need more of those kinds of testing. But I think what we're more interested in today is some meaningful test that's not too invasive, like something that they could spit into a tube and have the... And you can certainly measure secretory IgA in saliva. And if it's low, that means the defenses are down because it's elective protective. So when we talk about the secretory IgAs, when we talk about mucins, when we talk about opsonins and defensins, these are all elective. They are protective. So if you get exposed and you have protective mucosal systems, the virus will not get to your cells. And if it got to your cells, the innate immune system would be there to greet it. The tests, however, measure how common it is for people's innate immune system to be exhausted, overstimulated, and requiring of adaptive defense, either B cells that produce antibodies, but they come in two kinds, good and bad, and T cells, which are more important in these kinds of RNA viruses. So we need better testing. You can screen using saliva for secretory IgA. The PCR tests, there may be some PCR tests coming that will just require sputum, not the swab in the back of the nose. I have not had that done to myself, but no one that has had that done that I know, the few people that I know who had that screening, there's health professionals like at NIH who were screened. They don't want to do it again. It's uncomfortable to put the swab in the right place in the back of the nose. On the other hand, a self-administered disposable kit that allows you to just spit into it and then close it and return it has convenience, no question. But what if they put in, not sputum, because you have to cough up the sputum, what if they put in what most people have in their mouth, which is a combination of serosanguinous fluid? Brush your teeth and see the pink. That's a sign that your gums, your gingiva are not getting enough renewal and repair, enough ascorbate and magnesium choline citrate. Now you can collect pure saliva, and that is a reliable source to be analyzed, but it requires putting a little plastic disc over the parotid gland. It's called a Kirby cup. And when I was in graduate school, Frank Oppenheimer was studying special proteins in parotid saliva, in the same lab. So we got to collect pure parotid saliva for Frank. Most people don't want to do it more than once. And it takes about 4 or 5 hours to get enough pure parotid saliva. So when people spit, it's a combination of serosanguinous fluids, some submandibular and parotid saliva, and then there's a fluid at the base, the interface between the gums and the tooth. And when you spit, you get some of that. That can lead to falsely negative secretory IgA. Secretory IgA should be in the saliva, should be, but a lot of people are at risk. Look at how many people are getting sick. And the people at risk may be able to deliver some spit, but that's different than sputum.
So where is a more accurate way to collect total SIGA, if not saliva?
Well, the best way would be a Kirby cup. So then you get real pure parotid saliva, and now everything gets better in terms of the laboratory. I haven't heard of people using Kirby cups in a long time. I just happen to have been a donor of parotid saliva. A healthy person will have secretory IgA in their saliva. However, the most common acquired immune deficiency in America is IgA and secretory IgA deficiency because it's elective. The body doesn't have to make it. It makes it when it has enough energy, enough ATP and magnesium, enough proton gradient, enough ATP coming out of the mitochondrial battery. So it's elective and protective. And I have found a couple of articles. I sent at least one to Melissa, which I want her to share with you. There are a couple that I found about saliva testing on sputum and why you don't want spit, you do want sputum. Now, for symptomatic people, it should be easy for them to give you some sputum, but you have correctly raised the huge question of, can a person be a carrier without being sick? And there, the best data that I know comes from UCSF Stanford, and it has been now replicated in New York City. And what it says is there are between 20 and maybe 100 asymptomatic carriers or asymptomatic exposures with a response for everyone who gets sick. That changes the whole math. Now, this is definitely true in the Bay Area, where they did the first early proper mass screening and mass tracking and tracing and so forth. So clearly, like almost every virus, there are a lot of people who have seen it, but it has not harmed them. Now, can they transmit to others? Maybe. Remember Typhoid Mary? Some people don't get sick, but they still carry. And when they cough, sneeze, or wheeze, they can put little droplets in the air. And then it gets more complicated, because for every infectious COVID particle, there appear to be 100 capsular antigens that have no RNA and are impotent. They are not infectious. So if you could measure the coat protein on the coronavirus, which is the first thing that people have been measuring with IgM and IgG, it might turn out to be the same as hepatitis. With hepatitis today, at least the hepatologists that I rely on, they measure the core, that is the DNA of the virus, in this case it would be an RNA, as well as the capsule. Because Bruce Blumberg, in part, got the Nobel Prize for figuring out hepatitis and susceptibility. And in hindsight, it was antioxidant deficit, too much of the persisting pollutants, solvent residues, toxic metals, mold exposures, and radioisotope. Basically knocking off the Kupffer cells, knocking off the lining cells, which are immune competent cells. And when those Kupffer cells are present, if your liver gets to filter a virus, they stop it. But they are very energy intensive cells, and people at risk, comorbid people, very often don't have functioning Kupffer cells, and they may or may not even have Kupffer cells. But these are, again, elective protective cells that I think we need to be grateful to have, and to do everything we can to be nice to.
So the antibody testing that the Dr. Fauci wants so badly hasn't been developed yet. We're not even close, right? To have meaningful data from the antibodies that we're looking at?
Well, yes, NIAID has just funded a 10,000 person trial where they will be using a not yet clinically available tool to distinguish good from bad IgG antibodies. And as Tony and Dr. Birx and others have said, we need information about the T cells, which you can only get from a lymphocyte response assay.
And is there a specific lymphocyte response assay for T cells?
Well, this is, of course, what we have been providing since the early 1980s.
Cell competence.
The LRA by ELISA Act is the gold standard for precision and clinical, peer-reviewed studies. And we are actively seeking to collaborate to produce a COVID-19 specific LRA.
Okay.
Because the lymphocyte response assay distinguishes helpful from harmful antibodies, gives you immune complex information, and gives you T cell information all in one mixed cell culture. But it's got to be a cell culture. It's got to be a cell culture.
Got it. In theory, if we say we're spewing 100 particles of virus that are not the infectious RNA, then the vast majority of people who are asymptomatic are probably reacting to those and never really got the infectious RNA.
You're a smart lady, and I've always known that. And yes, I said it in a much more complicated way. You said it in a very clear way. If you look at the infrared and laser videos of people sneezing and coughing, you would conclude that we should all be wearing masks. The mask protects the person who is infectious from making someone else sick. It doesn't, if you're not infectious, it just interferes with your life. And if it's not an N95 or better, it's cosmetic. So I see a lot of these disposable masks. They have been very common in Hong Kong and in Japan for quite some time. They're now on back order by the billions, I think. I don't quote me on that. But N95 or better if you want to protect yourself.
Going back to the capsules without the RNA.
Yes.
So presumably they came from someone who, I mean, they didn't come from, so if someone is spewing them out, that means that, that they themselves have acquired the virus and replicated it inside their cells, and their cells are making a bunch of duds, and for every 100 duds, they make one real one.
But no, it's more interesting than that. Yes, there are definitely people who have a partial protective immune response, and they encourage the proliferation of the capsule, but not the RNA polymerase, which is required for the infectious component. So that turns out to be a helpful response, not an optimum one, but a helpful response. And in the UCSF Stanford surveys, there appear to be 25 to maybe 100 of those people for everyone who gets symptomatic, for everyone who actually lets the RNA polymerase take over and replicate the full virus.
So the prevalence, you said the prevalence of the people who mostly spew out duds is 25 per 100 maybe people?
No, 25 to 100 of those people who are exposed but not infected for every one symptomatic person in the community.
I see.
This is very difficult work to do. You've got to have testing and tracking and tracing, and the tests have to be meaningful and they got to be done right. But they were the first. The people in Seattle are collaborating with the people at NYU, and we'll see what comes out of that one. But among our nation's best and brightest in regard to pandemic preparation and response are the folks at UCSF and Stanford. Now, I've actually reached out to the people who did the study, but they're a little busy right now, and getting them for tea time is not so easy. But yes, in New York City, it appears that 20% of the population and a much higher percentage of public service people have been exposed. And of course, only a small fraction of them are getting sick. And the people who are getting sick have the comorbidities, and the people who are getting sick are the ones who have the comorbidities linked to antioxidant deficit like ascorbate and magnesium deficit, which is metabolic acidosis and proton gradient collapse, which means your battery doesn't charge.
Butts, can I ask you to pull out your crystal ball?
Sure.
Do you think that people will become immune to this coronavirus, get it, and recover? Or is it much like the common cold? We're going to get it whenever it comes around if we're not strong enough.
Well, with regard to the common cold, or the flu as they call it, if you used the vaccine, which I do not recommend, but if you use the vaccine, you are getting, quote, immunized to last year's strain.
Right.
And these viruses are promiscuous. These viruses are constantly changing. Not only is there COVID-19, there's COVID 20, 21, 22, and 23, but we're not sure whether there's cross-reactivity. If you got protected to 19, would you be protected from 22? We're not even sure how aggressive they are, because short of COVID-19, before COVID-19, coronaviruses were ubiquitous.
Right. Sure.
And benign.
Correct.
Now, if there are 25 to 100, quote, asymptomatic responders for every sick person, when you end up doing the math, COVID-19 is less aggressive than the seasonal flu. And the people who are having catastrophes are the antioxidant deficient, magnesium deficient people.
And so we don't yet know if a COVID-19 patient will be protected against a future COVID-19 infection, let alone the 2021-22.
All correct, because you know whether there's an antibody or not, But if there's not an antibody and the person was symptomatic, then either you missed the diagnosis or there's something wrong with their immune system. And if
Or the test.
if the T cells are important as they are, then it becomes more important to distinguish good from bad, neutralizing from harmful antibodies, and also measure T cell function in order to find out who is really protected and who is really at risk.
Right. I was reading about SARS-CoV, the original.
Right.
It said that that the IgMs often didn't become positive for 30 days, and the IgGs in some cases not until 90 days.
Right.
And then the IgGs begin to wane.
Right.
How low they wasn't determined because they didn't test long enough. But so I'm also concerned with our antibody testing for SARS-CoV-2 that we're testing too soon and therefore missing the window because we've tested and, oh, you didn't have it, but you really did if you'd waited 60 or 90 days and tested again.
We're in complete agreement. We're in complete agreement. Now, if you look at the quote literature, which is based on healthy normal volunteers, IgM comes up more quickly. But these are not, these are people with comorbidities, almost everyone, including vaping. And you'd be surprised how much hypertension there is in teenagers today and so forth. So we need testing where the results are meaningful. If you don't have the problem, it should not pick up much, if anything. And if you do have the problem, it should give you a meaningful result. But when Nora Lynn is the person who runs the lab and makes sure our quality control is exceptional. So she went out to find the kits that would allow us to offer an IgM, IgG test. And if you just look at their literature, you would think the IgM comes up within a week or two. And I said, Nora Lynn, I want you to go out and look on, PubMed.gov and look at, quality sources of peer-reviewed literature. And she came back and said exactly what you said, Ellie. These are the very people whose blunted immune response often takes time to show, which means the IgM will come up more slowly and probably linger a little longer because the IgG may or may not come up. But what if the T cells responded? So we very quickly get back, from my point of view, to functional testing that isn't quite available in the routine now. And if you do an IgG, IgM, and there are EUAs, there are companies that are permitted to sell IgM, IgG antibody tests today, although they're all back ordered as far as I can tell.
Right.
But those, as soon as the ports open up, the reagents will come in. I'm only laughing because otherwise I would cry about this, but we were woefully underprepared and didn't even read the report because there was a pandemic preparedness report, and earlier in this administration, they discontinued that because we didn't need to be any more prepared for a pandemic than we are now. So here we are. And, to be more specific about the answer, I think that measuring IgG and IgM is a good thing to do, and I would always do it 60 days later.
So most of the people asking to be sick weren't sick, asking to be tested, weren't sick 60 days ago. They were sick last week or a month ago. But
all correct. And you have the pre-drome, the drome, and the post-drome, if you will.
Right.
So there's the time when they are infectious, but they're not yet sick. Then there's the time when their body's immune system is fighting back and they're feeling terrible. And then hopefully they recover from that with the help of, good health and hygiene, restorative sleep. Don't get too worried about it. It's just a passing miasm. Oh dear. But testing, I think that all healthcare workers should have PCR tests and have those tests on a regular basis, the PCR.
just like we do for flu or strep.
Yes. Well, since you mentioned strep, when I was a young laboratorian, my boss, Don Young, comes to me and says, the director of NIH's son, who was about 9, was carrying beta strep, beta hemolytic strep, the bad strep. And so I say to Jim McLowry, who was our head of microbiology, I was wet behind the ears. I said, Jim, what are we going to treat the kid with? He looks at me, says, we're not going to treat him. Why? If you treat him, the organism comes back in a more aggressive form, and he's a carrier. So what we're going to do is have him gargle with vitamin C. That was Jim McLowry. He is at least a decade older, still a mentor. He's in the Portland area. Last time I checked, he was still supervising the labs at University of Oregon at Portland. And he taught me that, and he actually said this to me, he said, fools rush in where angels fear to tread. So our treatments are antimicrobial, antiviral, anti-this, anti-that. I am out of the anti-business. I'm in the pro-repair business. I'm in the personalized predictive primary prevention practice protocol business. But I very often, someone will ask me about a case, and the essence of the question is, what mystery infection do they have? And very often my response is, they have a lifestyle deficit. You know, if they would do a C cleanse and check their digestive transit time and stay hydrated and know that you're staying hydrated. Keep your urine sunshine yellow so you're getting enough B complex. These are proactive and really protective steps. And I think we're all in agreement that that's what we want people to do. But if you just listen to the cable news, which continues to go out saying, don't worry, but be very afraid. and yes, you can mingle, but only with up to 2 or some, I don't know. It's somewhere between, we have to have words coming out of our mouth because we're paid a lot of money as a pundit. And what the hell are you talking about? Because you clearly don't know the subject.
There's a lot of fools rushing in these days.
There are. Now, I would listen to Tony Fauci, and I thought that SNL bit with Brad Pitt was just priceless. I think Dr. Birx is trying to walk a fine line. Most of the people who I would like to hear from have been sidelined. So the guy who runs CDC, I would like to hear from him. And I'd like to hear from a whole bunch of people who, at the moment, have been literally sidelined.
Or silenced.
Same. No, that's the same. Now, silence is even more ominous to me, but sidelined and silenced are equivalent in terms of this conversation. So the people who speak don't know, and the people who know are discouraged from speaking. And God bless Tony Fauci. I think you probably know this. He is 79 going on 80, bright-eyed and bushy-tailed. He always has been the first one in and a diligent guy who happens to believe in the gospel of vaccines. And I don't happen to worship in that gospel anymore. But, you know, with that, you know, none of us is perfect. I do think that he does not, I think that what he says, he thinks about ahead of time, and he means what he says.
Oscar, what other questions did you have about testing?
Yeah.
Well, I mean, I think we can all agree that when our systems are working well, immune and endocrine and, you know, redox systems, you know, everyone is good for no matter what, be it cancer or a virus or a, you know, anything short of an anvil falling in our head. But from, you know, to quell the fears in the populace of A, do I have it? B, will I get it? C, will I recover from it? And D, am I infectious? What combination of tests, and you mentioned timing as well. I mean, obviously it would be great if everyone ran, you know, ELISA and vitamin D and zinc and red blood cell magnesium and IgG and IgM. And I've seen also COVID IgA, which I think is interesting, and, you know, maybe total salivary IgA, and just did it every 3 weeks. but that's not really feasible. So if you were going to narrow down your recommendations to see, you know, do I have it? Have I had it? Am I probably good to go? What would your thoughts be on that regard?
Have you had a chance to take a look at what we released, I guess a week or 10 days ago, our risk reduction protocol?
I saw your original recommendations for what you put out about a month ago.
This is very similar. I'm glad to tell you that nothing fundamentally has changed, but it's prettier, it's more consumer friendly. It was the basis for 2 articles in medium.com, which says it is an objective way to post information promptly without peer review. One is called the User's Guide to Vitamin C, and the other is called a Risk Reduction Protocol. These were co-authored by Amory Levins and Dr. Eric Rasmussen, but based on what we originally put out. And as I said, in the last few weeks, there is a lot more support for what we originally said. And with Liz and some other people's help, I think this is much more consumer friendly, easily read. You have 7 lifestyle opportunities to improve your immune defense and repair, neurohormonal balance and tolerance. And then 7 supplements that you can determine the need for based on self-assessments and similar. And so that is what we recommend. And the User's Guide to Vitamin C was downloaded 30,000 times in the first 3 days. So when Eric Rasmussen, who was the Surgeon General of the 3rd Fleet and has been doing disaster preparedness and response for 20 years, he has a community. Amory Levins, because of his work on sustainability and energy conservation, recycling, renewal, etc., Rocky Mountain Institute work, has a following. For those who have the eyes and ears, we have a Save Your Life and Save the Life of Those You Love plan that, if you're willing to invest about 5% of your day in yourself, you can do everything we're talking about. And if you want to, you know, pick the ones that you think are more important, fine. If you've lost your sense of taste and smell, it's probably related to zinc deficiency, which follows the magnesium deficiency. And red cell magnesium, Patty Doister showed many years ago, was not reliable. So Ron Aline, about 15 years ago, showed that if you're in the lower half of the serum magnesium range, easily available and easily done. If you're in the lower half of the serum magnesium range, you have chronic latent magnesium deficiency in your cells. CLMD is the acronym. And you want to move people into the upper half of the serum range to reduce the myriad consequences of magnesium deficiency.
Who disproved red cell magnesium?
Oh, her name is Patricia. Last name is Doister, D-E-U-S-T-E-R. She is a professor of military and stress medicine at the Uniformed Services University of the Health Sciences. Her lab gets to test our special forces to see if they're ready for mission or too stressed out. And I was the minister that married her to Greg, her husband, who's also a scientist at USUHS. So Patty and I go back to my time at NIH, the 70s. So she spent years looking at white cell magnesium, red cell magnesium, buccal magnesium, and so forth. And then finally, Ron Aline, who was a friend of both of ours, published this about chronic latent magnesium deficiency. And that is where the state of the art has been for the last 10, 15 years.
Russ, you know everybody.
No, but it's like 1 or 2 degrees of separation. If you have friends who have friends, then it seems like you know everybody. But in fact, you only know a few people. But if you know the right few people like you folks, it's all fun and worth it. Brian?
Elastin. I read your article, or your comments, and more, if you could elaborate more on the elastin.
Oh, sure. So now we're going to switch to connective tissue collagen and the elastin?
Yes.
Okay. Now, collagen we know of. Collagen is like ropes. The unique quality of collagen is that when it can and does polymerize in a very specific way, it becomes piezoelectric and you have very narrow but very long fibers insulated by what we call ground substance, glycosaminoglycan ground substance. Then, if the only thing you had to secure the infrastructure of your body was ropes, you wouldn't be very flexible or mobile. So the same system that makes for collagen makes for the compound called elastin. And elastin is like elastic. It's very wiggly flexible because of lysine-derived cross-links, specifically desmosine, isodesmosine, and lysinonorleucine. And my PhD was how penicillamine interferes with that cross-linking process and how to avoid that problem. But my boss, Carl, was the first one to identify lysinonorleucine. So elastin has these unique lysine-derived cross-links that make it very wiggly, that make it very elastic, that when you stretch it, it wants to come back, but it's very hard to break it. So elastin turns out to be like the forgotten cousin of collagen. Without elastin, we really couldn't have joints. We couldn't be mobile. What else would you like to know about elastin? Because I can go on for a long time about elastin.
Well, when I was read the information that Norm sent, it was cardiovascular, I believe, in nature, and the vitamin C connection.
Well, yes. So let's focus just on that.
Yeah.
You have things like atherosclerosis, coronary artery disease, small vessel disease, mitral valve prolapse, known as Barlow's syndrome. All of those are a lack of repair in the collagen and elastin of the heart. And ascorbate, among the many, many gifts it gives us, when we take it in sequence or however we get enough of it, when we get enough of the ascorbate, it optimizes the synthesis and repair of the connective tissue that is constantly wearing out and needs to be replaced. And if you have a repair deficit, clinically we call that inflammation. And if you have a more severe form of the same, we call that autoimmunity or self-attack.
Say that again. If you have
Yes.
a mild.
Right. If you have a mild repair deficit, we call that inflammation. And your hsCRP will be above 0.5. And probably your vitamin D will be low. But if you have adequate antioxidant ascorbate to donate the electrons to charge up the cell, and you have enough magnesium to activate the ATP, keep the proton gradient, which is necessary for the mitochondria to function. So you can survive on what's called anaerobic glycolysis, anaerobic breakdown of sugar, called Embden-Meyerhof. But it only produces 2 ATPs for every molecule you metabolize. If you have oxidative phosphorylation, the saprophytic benefit of the mitochondria is our cytoplasm protects the mitochondria can produce 36 ATP for every electron that flows down the cytochrome chain. And ascorbate is the only molecule in biology that can salvage the cytochrome, the 4th cytochrome, the last cytochrome, because that has a 0.5 millivolt gap, and ascorbate is the only molecule in biology that can donate an electron across that 0.5 millivolt gap. So ascorbate does many, many things to help us either survive or recover, including enhance repair, which is essential. If we repair, then our immune system stays tolerant, our neurohormonal balance is good, we get restorative sleep, we're nicer to ourselves and to others, life is better.
Okay. I used your latest print on the coronavirus last Sunday on my blog. We got 80 hits on that, which is
All right.
a lot for for my little show. So that was quite a bit. Very popular.
I very much enjoy what you're posting, and I think your wife kind of reads it ahead of time to make sure it's consumer friendly.
Yes.
But I'm so glad for you. I'm so glad, because we need people, whatever channel you have, we need people to tell what is so, and to admit when we have need of more data or information or clarification. And, you know, we're doing it through our YouTube channel, which is getting more and more traction. We're doing it through the summits that are eager for this message, having to do with the host resilience, resistance, and hospitality. And that's the part of the discussion that most of the people, for reasons I don't understand, they kind of give it lip service, but then they kind of jump over that into, and here's what the vice president said yesterday.
Yeah.
Russ, the hypercoagulability stroke in young people thing, do you think
Yes.
that's purely a symptom of ascorbate deficiency, or is there more to the story?
Yes. No, it is almost the definition of acute scurvy and metabolic acidosis. It is almost the definition of a loss of ascorbate and a lack of magnesium in the cells. Because when the lining cells of the blood vessels are known as endothelial cells, endothelial cells are constantly being cleaned and renewed by platelets and white cells because of what's called laminar flow in blood vessels. And this is called the marginating pool of cells that keeps the lining intact. Because if the endothelial cell falls off, you expose collagen that activates platelets. And that was what Dan Dakin and I published in 1973. That commercial's now over for that. But when you lose an endothelial cell, if you're healthy enough, a carpet of platelets covers it so that a mesenchymal muscle cell can wiggle up to the surface and become an endothelial cell and restore the integrity of your blood vessels. But if you have antioxidant collapse, the oxidation reduction potential goes high, and the endothelial cells get unhappy quickly and fall off. And if a bunch of endothelial cells fall off, now the platelets can't just form a monolayer carpet. The platelets get activated by all that collagen activation, which is a repair signal, but in this case it's a catastrophe, and you have DIC, disseminated intravascular coagulation, DIC, marked by D-dimers in the urine. That was Jaime Nasso's contribution, marked by an acute rise in C-reactive protein. HSCRP can go to very high numbers. You use up vitamin D and K2 very quickly, and catastrophe ensues in the form of these micro and macrovascular coagulopathies.
Would you see high fibrinogen as well?
Well, fibrinogen is inducible. So fibrinogen will initially go up, but those D-dimers are clipped off of fibrinogen in the process of turning it into fibrin. You want fibrin to stop bleeding. You don't want fibrin floating around in your blood. That was Russ Doolittle's work.
So you briefly mentioned at the start of this, we'd talk about vitamin C, how much and what kind.
Sure.
So at what point in a COVID-19 infection should we switch from oral to IVC?
Oh, okay. As soon as they have labored breathing, I believe, based on the clinical information that is still, I think, in peer review, but has been posted, at least 6 grams, preferably 25 grams by vein, at least once, maybe twice a day. Now, I will extend that to say, if you can measure plasma ascorbate, you want a peak level of 50 to 80, but the next infusion should still have a trough level, a pre-infusion level that is beneficial, which is 10 to 15. Now, if you get in a little bit earlier when they have labored breathing, then any amount of ascorbate by mouth or vein is helpful. And I would move the conversation upstream to say anyone who might be exposed, has been exposed, knows anyone who's exposed, should be doing a C cleanse orally, and they'd be impressed and surprised at how much ascorbate it takes between distress and exposure. 21st century, we're marinating in this sea of anti-nutrients. And since ascorbate uniquely sets the oxidation reduction potential of the cell, and when your redox is low and you have enough ascorbate, you do not allow viruses to multiply. Viruses require a high redox, which means a low ascorbate. And they like it to be a little acidic inside the cell, which means magnesium deficient.
I spoke to Rick Eng and David Brownstein, and their protocol in Michigan is they're giving IV vitamin C 6 grams a day for 3 days, and vitamin C 1,000 every hour to bowel tolerance.
Yes, that is exactly what they're doing, and they picked that up from a guy who was prevented from giving more even though he wanted to.
Yeah. And they said they've had no deaths and very few hospitalizations. So.
I do think that the earlier you get in with people at risk, the better the outcomes.
So narrowing it down to, if you can, to just a few tests that, again, I have my own patients where I measure, the homocysteines, the CRP, all the things, not all the things, but a lot of the things, but for their friends and neighbors and populace, I'm thinking, even though it's not a perfect, none of these singularly are perfect tests, but together, I'm thinking a salivary IgA because it's relatively inexpensive and very easy, vitamin D, COVID IgG and A, and then repeat in 3 to 6 weeks out.
Which comorbidities do these people have? Because the ones you're really concerned about have comorbidities.
Yeah, I mean, if they're my patients, we're addressing that obviously, but for the general populace.
If I can interrupt, Oscar, are you measuring FEV1?
No, he's not.
No.
Okay. This is forced expiratory volume in 1 second. FEV1, it's very inexpensive to do and gives you a pretty decent screening assessment, but a very clinically reliable measure of their breathing. And since
aren't you at risk for spewing? I mean, that's a very hard test to do. And
I didn't say to stand in front of them when they do that. I have people use disposable units. They're very cheap. And I trust them to record what it says, because you've got this little gauge, and the more you go, the better, of course. But we have to practice appropriate social distancing. We just have to. However, you can still do an FEV1, remotely.
Like with an incentive spirometer?
Yes. There are disposable plastic spirometers specifically designed for FEV1 and to be self-administered. So that is one, just building on what you were saying, Oscar, because we're in agreement. You want to do something meaningful, actionable, and significant,
and cost effective.
But you don't want to miss something that is easily also addressable. For example, if they've got weight issues, if they're sedentary, if you have any reason to suspect a hemoglobin A1C above 5%, for every percent your hemoglobin A1C goes up, your immune competence, immune defense and repair abilities go down by about 20%.
Above 5?
So that means that many people who are walking around, quote, adapted to their blood sugar of 175 or 200 are absolutely at risk. And you can do something about that. They're sweet enough as they are. Just take them off of added sugar and it'll come down.
You said, so for every point above 5, so if it's if at 5, it's okay. At 6, it's 20% lower. At 7, it's 20% lower than that.
At 7, it's 40% below 5. At 8, it's 60% below 5. It's an almost linear decline. So I would definitely measure the vitamin D because the country is low and that's no excuse. I think the omega-3 index, Bill Harris's omega-3 index, is worth doing. I think for many of these people, it's worth offering salivary male and female hormones, cortisol at 4 times DHEA, estrogens, including estriol. You want to know the good estrogen as well as the bad estrogens, free testosterone, progesterone, DHEA, and a lot of these folks, the ones who are coming to you, the walking, worried, wounded, they will often be low in DHEA and progesterone, and that's correctable. But I don't recommend the cream, too variable in uptake and too variable in effects. So use a good compounding pharmacy for the hormones. Now, if you can, I would think about whether they might be pituitary thyroid exhausted, and I would at least measure TSH free T3 and free T4. And if you have reason to suspect, do the reverse T3.
Dr. Jaffe, can I ask a question that's not related to COVID?
Sure.
I have a patient that is suffering with pretty significant anxiety. And since she's been taking her magnesium and choline, she's been feeling better.
Good.
But yesterday, when I talked to her, she said, you know, for the first time for the past week, every time I take the choline, my stomach hurts for a little bit before bed. And she said, you know, it's really, really uncomfortable. And I said, well, maybe you should stop taking it for a couple of days and let's see if that actually resolves it. She refuses though. She's like, I'm not going to stop taking it because I feel too good when I take it and I can grin and bear it.
Okay, no. Look, we always respond to the individual. We don't hear that very often, but let's say she has a delicate tummy. That's okay. And let's say, for sake of discussion, the choline is going to produce acetylcholine in her gut and central nervous system. That's helpful to her. It's going along with inositol to regulate certain cell functions in digestion. Now, the fact that she says she's able to bear the affliction, the discomfort, to me says, let me think about what might help her not have that effect. For example, could she make a little nut butter herself? Or could she get some organic peanut butter? Mm-hmm. Not too much. She's going to bed. You know, you don't want to go to bed with a full stomach. But my hunch is we could find something that either she takes along with the choline citrate and magnesium, or that she mixes the choline citrate into, so that the uptake in her stomach won't be so fast. Okay. I think what she's sensing is this rapid uptake because her body is so hungry for it. Mm-hmm. But, you know, it's always the Goldilocks scenario, not too much, not too little, just right is just right. So commend her for appreciating. You might think about adding what we call mood guard. You might also think about adding what we call sleep guard and the salt and soda baths to help her relax into the time for sleep.
Okay, I'll do that. Thank you.
Oh, sure. Any bonus round questions?
I mentioned the SIGA on COVID. Any thoughts on that?
Oh, I'm in agreement with you. As soon as there's a reliable secretory IgA for COVID-19, you'll hear about it from us, or you'll tell us if you hear about it first. But what I've asked Melissa to send you are a couple of articles about why, if you want to measure secretory IgA for COVID, you need sputum, not saliva.
I meant there's the Vibrant America test somehow has not SIGA. I meant just IgA for COVID, which I hadn't seen anyone offer before.
They removed that, Oscar.
Go ahead.
Oh, they didn't.
They just removed that the other day. Yes, they're just doing IgG.
No, that's exactly right. I was just going to say IgA is interesting, but to the best of my knowledge, there is no, quote, triple test. And if you separately measure IgM, IgG, and IgA, the cost will be prohibitive. And so to the best of my knowledge, they have gone, and I think this is a smart direction, a combined IgG, IgM test. Now, I'm still a fan of secretory IgA, I am. And if you could get a reliable COVID-19 for IgA, that would tell you something about the mucosal hospitality and response, immune response to the virus. You wouldn't tell all the things you need, though.
What's the potential ETA on you guys offering LRA for COVID?
Thank you for asking. I will now be polite because you know it's like, since I'm not done, and you know, in the common parlance, stuff happens. I can tell you that just when we started to want to offer a reliable IgM, IgG for COVID-19, like a lot of laboratorians, we were very unimpressed with what we could get. And what we wanted was so backordered that if you held your breath that long, you wouldn't be able to. We are in a collaboration. We're trying to finalize the details so that we get the right antigen, because you don't want to measure the wrong antigen. You don't want a cross-reactive general corona antigen. You want something COVID-19 specific. So we're in very active discussion about getting enough antigen into our system, because once it's in our buffer and our ability to get it onto the plates, then we can do what's necessary, which is a validation study. Because in most of these tests, if you put in too little, you won't detect anything. If you put in too much, 100% of the people will be positive, and that's not reliable. You have to do a dose response curve, and then hopefully you do enough of that to show it to the people, your real data, not the data from the Jonathan Brostoff textbook or the Irving Riot textbook. The answer is, it is a priority to us. We don't have control yet of every step, but we are being encouraged by my old friends at NIH and NIAID to do this, because they would like to know that information too. So I can't give you a date because we're not in control of every step along the way, but we've done this over the years for over 500 different items. You know, we have the largest number of foods and preservatives, toxins and medications to test for, because we do purify every one of our own antigens. The commercial antigens are really pretty schmutzy.
So in a perfect world, when you have all your reagents, how long has it taken you historically to go from an antigen identification to a test?
Within a month, maybe less. So it is a priority to us. Thanks for asking that way, because that one I know the answer to. Once we have control of the validation of the dose response curve, less than a month. And then you get an interesting question, which is, how do you know that the people who are unaffected are unaffected? How do you know that the people who are affected are being properly detected? And that's where the validation cross-correlation comes in. So we will correlate our functional results with other, what I call physical chemistry tests, show the superiority of the cells. And then more importantly, you can do things called blocking. So you think you have a reaction to COVID-19 because it's the thing that you coded on the plate, but maybe the cells were just overly enthusiastic that moment. So you can put in what are called blocking antibodies to confirm that the result you see is a meaningful and significant result. And then you have to do enough to get statistics. And you know, that's a bunch, but it's not an onerous burden. It does help to have known Galen and Gambino, though. And then, you know, I still have good relations with my old friends, even though I went away from their wagon train. because we're not the only people who are eager to get a functional T and B cell distinction test for COVID-19. And with their help, and we believe that they are trying to help us as we're trying to help them, we can get through to the point where I can see, you know, the light at the end of the tunnel, and it's not a freight train coming at us. It really is, you know, a candle in the dark or something to mix the metaphors.
Any thoughts on using ventilators, given the pathophysiology of COVID-19 with people that are already in high distress, and thoughts on the, you know, the elastin, which you mentioned, hyaluronic acid potentially being introduced directly, or hyaluronidase, versus, you know, trying to open up the holes rather than just, you know, pump pressured air through them?
Well, the implications of what I said is that in almost every case, including the people with the terrible comorbidities, you should be able to get in there early enough with the ascorbate oral and, if necessary, IV, and the magnesium choline citrate to prevent the catastrophe. Once you have someone on a ventilator in an institution or a hospital, now you have a protocol to follow. Not my protocol. A protocol. I have never found it easy to shift an institutional protocol, especially while the patient was still alive. And as a doubly board certified pathologist and internist, I can tell you it's not that they're pig-headed, it's not that they're dumb in any way, it's that they don't know what we know. And educating people on the fly, I had to remind a very senior physician at Columbia University that Jaime Nassel was the person who discovered this low-grade DIC that is part of the COVID morphology and catastrophe. He was a professor at Columbia, and they barely remembered his work. And then they came back and said, "How did you know that? Because it's not easy to find on the internet." I said, "I'm older than the internet. That's how I knew Jaime Nassel." So I think we need to be more functional and cross-trained. I think we need to be more understanding of the causes, not the consequences. And I think many of the interventions that are being used today confuse consequence and cause.
That was a delicate PC way of saying it, but let's just pretend that you could do anything you wanted and someone has already stepped in it. What would you, you know, besides the, you know, you've missed prevention specifically with regards to ventilators. What's your opinion on that?
Oh, if you're in that regard, they must be prone, and you probably have sedated them because they're going to fight the ventilator. Well, tighter that. Talk to them. They may not be able to respond, but I just saw, I think it was a nurse, it might have been a physician, who really got attached to a particular patient on a ventilator, and the patient is now recovering on day 17 or 18, but for 14 days was on a ventilator, and she talked to the patient. And after the patient came out of it, the patient said part of the reason that the patient survived was that this person held their hand and talk to them, you know, the way I think you should, respectfully and with empathy, and, you know, as if this was your mother, father, sister, brother, daughter. And of course, anyone who is on a ventilator should be receiving, in my observation, 25 grams of ascorbate at least once or twice a day, sufficient to keep your peak level 50 to 80 and your trough level 10 to 15. If you combine that with the magnesium choline citrate, which you can do by NG tube if you had to, but if you combine that with the choline citrate and magnesium, I believe that the ventilator time in the few anecdotal studies in South Korea, in Hong Kong, and in Canada that we are in touch with, it has reduced the ventilator time by 80 to 90%. And the issue about the ventilator is how long are they on it? It's a declining slope. The longer they're on it, the worse it's going to be, the outcome. But I learned from Ed Gensler and John Knowles and Jonathan West. These were people who pioneered the field of pulmonology when we were just intubating people randomly to see what was happening. So that would be my suggestion, but I would be willing to talk to any colleague who has ventilator candidates, because apparently you can go from labored breathing to needing a ventilator in a very short period of time. But that's the way it is with acute scurvy. And you know, if you started the vitamin C with the labored breathing and the magnesium choline citrate with the labored breathing, I think you could reduce the need for ventilators dramatically.
Are you friends with Cuomo?
It's a curious story, but his mother, Matilda, is very close to the man who has done more sea cleanses than any human being. His name is Ed Morris. He's in Seattle. So have I photographs with them? Yes. But, you know, would he, if I tripped him, you know, in a room, would he remember? I doubt it. I admire the governor of New York. I am aware, although I had nothing to do with it, that his brother Chris's wife was using IV vitamins to help her recover from COVID.
And yet the FBI raided a clinic that was doing IV vitamin C.
Yes, and that was last week in the Detroit area. If there's any consolation, there were no arrests. But they stayed all day. And I believe that when you see FBI people in these flak jacket suits and guns and stuff, it's not good for morale.
No. If they show up in my office, Russ, I'll have them call you.
Oh, by all means. I mean, not that I can do a lot, but in my day I could have. The bottom line there is that if you're going to use intravenous vitamin C in someone that you have diagnosed with COVID-19, do it under IRB approval.
Yeah, there's no IRB relationship that most of us have with any hospital, clinic, office, anywhere.
I'm just giving you good advice on advice of counsel. I understand, Ellie, what you're saying, but I will tell you that there are at least 3 that I know of, and possibly another group, that are doing their best to get IRB approval for their community-based intravenous ascorbate protocol.
Got it. Okay.
So stay tuned on that. Stay tuned on that.